Hi everyone, and welcome to our module on sickle cell anemia. Let's start by briefly reviewing the causes of normocytic anemias. Normocytic anemias are anemias where the MCV is normal between 80 and 100. You can develop a normocytic anemia if you have underproduction of red cells from the bone marrow. These are called non-hemolytic normocytic anemias, and we'll talk about these in other modules. The hemolytic anemias are normocytic anemias where there's increased destruction of the red cells. This can occur for reasons outside of the red cell. These are called extrinsic hemolytic anemias, and I have a module on all of these. But these can also occur due to something intrinsic to the red cell. In other words, a normal part of the red cell which is not functioning properly, and that is causing hemolysis. And one of the examples of an intrinsic cause of hemolytic anemia is sickle cell anemia, and this is a particularly important and high-yield disorder. It's very common in clinical practice, so that's why we're going to have an entire module on sickle cell now. This is a genetic disorder. It is an autosomal recessive disorder, and it is caused by abnormal beta hemoglobin chains. Recall that beta chains are found in hemoglobin A. Hemoglobin A is made up of 2 alpha chains and 2 beta chains, and this is the most common type of hemoglobin in the adult. It makes up 95% of adult hemoglobin. Each of us is born with 2 beta globin genes. We get one gene from each of our parents, and those genes code for the beta globin proteins that are found in hemoglobin. The root cause of sickle cell anemia is an abnormal beta globin gene. Specifically, children born with sickle cell anemia have a single base substitution at the 6th codon of the beta globin gene. Recall that genes are made up of DNA which contains nucleotides, and nucleotides include a base. In sickle cell anemia, a base that is supposed to be adenine is changed to thymine. This results in production of an abnormal beta globin protein, which leads to formation of an abnormal type of hemoglobin called hemoglobin S. At the top right side of the screen, I've shown the normal situation that we're all supposed to be born with 2 normal, healthy beta globin genes. In children born with what's called sickle cell trait, they have 1 normal beta globin gene and 1 abnormal gene. The normal beta globin gene forms normal beta globin proteins, and those can be matched with alpha globin proteins to make hemoglobin A. The abnormal gene, however, makes abnormal beta globin proteins, and when those are linked up with alpha globin proteins, they form hemoglobin S. Children who are born with sickle cell disease have 2 abnormal beta globin genes. As a result, they can't make any normal hemoglobin A, and they make only hemoglobin S. The nucleotide substitution in the beta globin gene leads to an amino acid substitution in the beta globin proteins. In patients with sickle cell anemia, there is a substitution of the amino acid valine for glutamate in beta chains. If you look at the bottom right side of the screen, this is the chemical structure of the amino acid glutamate. This can be found in the beta chains of normal hemoglobin. You can see that it has many oxygen atoms, and therefore it is polar and hydrophilic. In patients who have sickle cell anemia, a glutamate amino acid is exchanged for a valine. Valine has many more carbon-hydrogen groups. This makes it a nonpolar molecule and much more hydrophobic compared to glutamate. This will alter the shape of the beta chains, and that's responsible for the pathology of sickle cell anemia. By way of review, there are 3 types of normally occurring hemoglobin. Hemoglobin A is the most common type in the adults. It's 95% of our hemoglobin. It's made up of 2 alpha and 2 beta chains. Hemoglobin A2 is the less common adult type of hemoglobin. It's usually less than 5% of our hemoglobin. It also has 2 alpha chains, but it has 2 delta chains instead of beta chains. And then finally, fetal hemoglobin has 2 alpha chains and 2 gamma chains. So the beta chains are only found in hemoglobin A, and this is where all the problems are going to result in patients who have sickle cell anemia. In addition, be aware that when patients are in utero and at birth, they have lots of hemoglobin F around. They are not producing many beta chains until a few months after they are born. Therefore, the signs and symptoms of sickle cell anemia usually are not a problem in utero or at birth. The problem with hemoglobin S is that when it becomes deoxygenated, it becomes insoluble, and the hemoglobin molecules will stick together and polymerize anytime the oxygen tension is low. Polymerization can also occur in settings like dehydration and acidosis, and as we will see later, these things can lead to an exacerbation of the symptoms of sickle cell anemia. When the hemoglobin S polymerizes, the red blood cells form crescent shapes in the peripheral smear. This is a picture of sickle cells shown in the screen. You can see these cells that look like a crescent. And when this disorder was first described, people thought that the crescent cells looked like a sickle. If you don't know what a sickle is, it's a farming instrument used to chop down wheat. So people thought these cells looked like sickles, so they called it sickle cell anemia. One special feature of these sickle cells is that they will decrease the erythrocyte sedimentation rate. In other modules, I've talked about how settings of inflammation can raise the erythrocyte sedimentation rate, and this blood test is sometimes performed to try and detect whether or not there is inflammation occurring in the body. The sickle cells are unusual in that they will lower the erythrocyte sedimentation rate. So from a clinical point of view, there are two major problems that result from sickled red blood cells. The first is hemolytic anemia. And if hemolytic anemia was the only thing that happened in sickle cell anemia, then sickle cell anemia would be very similar to beta thalassemia major. Beta thalassemia major is also a problem with the beta globin chains, and the major issue there is chronic hemolytic anemia. What's different about sickle cell anemia and what makes it a far more serious condition is that in addition to hemolytic anemia, vasoocclusion occurs in the small blood vessels. As we will see, those sickle cells can occlude the microvasculature, and this leads to a lot of unique symptoms in sickle cell anemia that you do not see in other types of hemolytic anemia. So first let's talk about the hemolysis that occurs in sickle cell anemia. The sickling of red blood cells is reversible. The cells continually sickle and desickle in the circulation, and this leads to red blood cell membrane damage. And as you may know, anytime the red blood cell membrane is damaged, those cells will be removed in the spleen. This will lead to extravascular hemolysis. So patients with sickle cell anemia can develop anemia and jaundice and elevated bilirubin and pigment gallstones and all the classic features of chronic hemolytic anemia. There is also some intravascular hemolysis that can also occur. Sometimes when the cells sickle and desickle, they simply rupture in the vasculature, and this leads to some level of intravascular hemolysis as well. Another consequence of sickle cell anemia is erythroid hyperplasia. This is the result of massive bone marrow expansion due to very high EPO levels. You don't see this much in the modern era because we treat sickle cell anemia, but years ago, children with untreated sickle cell anemia would have very high EPO levels, and this would lead to a massive expansion of their bone marrow, and this would lead to lots of bony abnormalities because the bone marrow was growing so large. This is the consequence of severe anemia, and you can see it in sickle cell anemia, but you can also see it in some beta thalassemia major cases. Once again, those children also have very high EPO levels. So what are the bony consequences of erythroid hypoplasia? Well, first of all, there are classic abnormalities of the skull and facial bones that used to be present years ago when children had untreated sickle cell anemia. The first one was called chipmunk facies. This is when the cheekbones would become enlarged from bone marrow hyperplasia and the children would look like they had swollen cheeks. This was called chipmunk facies. Another classic finding was the presence of a crew-cut appearance on X-ray of the skull. We don't usually X-ray children's skulls, but if you did X-ray the skull of a child with untreated sickle cell anemia, you would see that the skull bone would have these little flecks of bone sticking out of it. Those are evidence of the crew-cut appearance of the skull, and another classic finding in sickle cell anemia. In addition, children with sickle cell anemia can have delayed skeletal maturation. That's because the bone marrow is so active that the bones aren't growing normally. And then finally, widening of the marrow spaces from very high EPO levels in sickle cell anemia can lead to brittle bones and osteoporosis. Another consequence of the chronic hemolysis is that these patients can be in great danger if they become infected with parvovirus B19. This is a virus that infects red cell progenitor cells, and it can lead to a severe drop in the red blood cell count called aplastic crisis in patients with sickle cell anemia. These patients are highly dependent on their bone marrow given the chronic hemolysis. So if the bone marrow becomes impaired by a parvovirus B19 infection, this can lead to an aplastic crisis where the red blood cell count gets very low. An aplastic crisis after a B19 infection is also seen in spherocytosis and thalassemia and other disorders where there's chronic hemolysis and patients are highly dependent on their bone marrow. So now that we've talked about the hemolytic anemia side of sickle cell disease, let's talk about the other important feature of this disorder, and that is vasoocclusion. Those sickled red blood cells can occlude the microvasculature, and this leads to a number of the unique features of sickle cell anemia that are not seen in other types of chronic hemolytic anemia. The occlusion of the microvasculature can affect any organ. You can read about sickle cell anemia affecting the heart and the brain and any type of tissue that you can think of. What I'm going to focus on in the next few slides are the classic clinical manifestations of sickle cell anemia, which includes all of these items I've listed on the screen right here. The first classic manifestation is dactylitis. This is pain and swelling in the hands or feet as a result of occlusion of the microvasculature of those tissues. The fingers can become swollen and can look like sausage digits. This is a common initial symptom among children. This is sometimes why they are first brought to medical attention, and the workup ultimately leads to a diagnosis of sickle cell anemia. Another classic feature of sickle cell anemia is avascular necrosis. This is bony collapse, and this commonly affects the femoral head because the sickle cells occlude the vasculature at the femoral head. This is a picture of a femoral head. You can see how it's jagged and degraded along this portion I'm marking with my pen. That is the result of avascular necrosis. You can also see this for unclear reasons in long-term steroid use. The two classic associations of avascular necrosis are sickle cell anemia and long-term steroid use. Another classic feature of sickle cell anemia is the development of pain crises. These are episodes of acute pain. They're sometimes called a sickle cell crisis, where patients develop the sudden onset of pain. If you train in a place where there are patients with sickle cell anemia, you will meet many of them in the emergency room and in the hospital for treatment of these acute pain crises. This is the most common type of vaso-occlusive event. This can affect any part of the body, so they can have occlusion of the microvasculature in their abdomen, in their bones, in their joints, in their soft tissue, in their fingers and toes. Swollen hands or feet are especially common in children, as we talked about before, so they will present to the emergency room with severe pain, and what's happening is that they are having an exacerbation of the vaso-occlusion that occurs as part of their sickle cell anemia. The treatment is to hydrate these patients because dehydration can lead to sickling of cells, and also administer pain medications. And because of these recurrent episodes of pain medications, many patients with sickle cell anemia become dependent on narcotics, and that's a major issue in managing patients who have this disorder. One of the classic hallmarks of sickle cell anemia is splenic failure. Vaso-occlusion in the spleen leads to repeated splenic infarctions, and this leads to what's known as functional asplenia. So even though these patients still have their spleen, they behave as if they don't have a spleen. That's called functional asplenia. Early in the disease, the hemolysis can lead to splenomegaly. There can be hyperplasia of the macrophages, and the spleen can become enlarged. However, as the disease progresses and vaso-occlusive episodes occur, the spleen becomes infarcted and fibrosis and atrophy will develop, and therefore the spleen will stop functioning. And a classic finding in the peripheral smear of patients with sickle cell anemia, in addition to the sickle cells, is the presence of Howell-Jolly bodies. This is a picture of one shown on the screen, and these are found in the peripheral blood smear of patients who lack a functional spleen. Because patients with sickle cell disease have functional asplenia, they are at increased risk for infections by encapsulated bacteria. Your spleen is very important for clearing encapsulated bacteria from the bloodstream. So patients with sickle cell disease can get very sick and even die from infections with strep pneumonia and H. influenza. These are both encapsulated bacteria, and they can lead to bacteremia or sepsis, especially strep pneumonia. This is a common way that patients with sickle cell anemia can die. And for this reason, it's very important to vaccinate patients with sickle cell anemia against these two encapsulated bacteria. Another unusual infection that patients with sickle cell anemia can develop is osteomyelitis from Salmonella species. The infarcted bones in this condition are ripe for infection, and Salmonella is an encapsulated bacteria. Now, usually osteomyelitis is caused by Staph aureus, but among patients who have sickle cell anemia, Salmonella is the most common cause, and that's believed to be because it's an encapsulated bacteria, and these patients are functionally asplenic. Another spleen complication of sickle cell anemia is called the splenic sequestration crisis. In this complication, vaso-occlusion of the spleen leads to pooling of red cells in the spleen. Basically, the spleen becomes obstructed by sickled cells, and all of the plasma and red cells pools inside of the spleen. There's a marked fall in the hemoglobin level and a rapidly enlarging spleen. This can lead to hypovolemic shock by trapping all the plasma and red cells in the spleen. This especially can happen to children. This happens in spleens that are yet to develop fibrosis, and that's true among children who have this condition. And sometimes this is the way the condition is first discovered. Before the child is diagnosed with sickle cell disease, they present to a physician with shock. There's pooling of red cells and an enlarged spleen, and the diagnosis of sickle cell disease is made after this complication develops. Another very common complication of sickle cell anemia that you are likely to see on your clinical rotations is called the sickle cell chest syndrome. In this complication, there is vaso-occlusion of the pulmonary microvasculature, and this is a very serious condition. It's the leading cause of death among adults with sickle cell disease. This is often triggered by infection, especially pneumonia. This will increase the amount of sickling in the lungs. Once sickling begins in the lungs, there's inflammation and acidosis, and this leads to more sickling. Sickle cell patients who develop the chest syndrome present with chest pain and shortness of breath. They will have an infiltrate on their chest x-ray, and it can look just like pneumonia. And in fact, it's treated with antibiotics because it's hard to tell whether pneumonia is present or not. The treatment involves fluid and pain medications similar to treating sickle cell pain crises, also antibiotics and oxygen and bronchodilators. This is very similar to the treatment of pneumonia. And then finally, transfusions are administered as needed to treat the anemia. Renal complications are common among patients with sickle cell anemia. In particular, there is often occlusion of the small blood vessels in the renal medulla. These vessels are called the vasa recta. The renal medulla has a low oxygen tension and a high osmolality, and both of these conditions favor sickling of the red blood cells. When the renal medulla becomes damaged from infarctions from sickled red blood cells, this can impair the concentrating ability of the kidney. Patients with sickle cell anemia sometimes are unable to raise their urine osmolality even when they are subjected to water deprivation. This can lead to nocturia and polyuria. These are all symptoms of being unable to concentrate the urine, and therefore dumping too much water out in the urine and urinating extra frequently as a result of inability to concentrate the urine. Here's a drawing of the nephron from some of our renal modules. Out here in the inner medulla, the concentration is very high. It can be as high as 1200 milliosms. This draws lots of water out in the descending loop of Henle. If this high concentration is abolished because of infarctions of the renal medulla from sickle cell anemia, then water will not be drawn out as it should be in the descending loop of Henle. This will result in more water going out in the urine, and the patient will complain of nocturia and polyuria. In addition, when you measure the osmolality of the urine, you will find that it is lower than it should be. That's because there's extra water in the urine diluting all the solutes down. Another renal complication that can occur is papillary necrosis. This is sloughing of the renal papillae due to renal vaso-occlusion. Recall that the papillae are these portions of the kidney that I'm circling with my pen. They collect urine from the nephrons. When they slough off, this usually results in painless gross hematuria and proteinuria. Now, the renal papillae, I should note, are right next to the renal medulla, so papillary necrosis often goes hand in hand with urinary concentrating problems and the polyuria and nocturia we talked about before. There are a number of treatments that can be used in sickle cell anemia. As I mentioned before, immunizations, especially against encapsulated bacteria, is very important. There is a drug that's often administered to these patients called hydroxyurea. It raises the amount of fetal hemoglobin. The mechanism of this effect is unclear, but when these patients have more fetal hemoglobin, they are less symptomatic. Transfusions are often administered, but iron overload may develop just like it does in other chronic hemolytic conditions where patients receive repeated blood transfusions. Bone marrow transplant is an emerging therapy. It's curative. When and how often to administer this to patients with sickle cell anemia is still a subject of a lot of debate. And the median survival for these patients, unfortunately, is not very long. Usually they die by about 42 to 48 years of age. Sickle cell trait is when patients have one mutated beta-globin gene. In this condition, there is usually no sickling. The reason for this is that the normal beta gene becomes more effective in this condition and generates more than 50% of the beta-globins. This leads to production of a significant amount of hemoglobin A. You need more than 50% of your hemoglobin to be hemoglobin S for sickling to occur, and therefore this is not a feature of sickle cell trait. The one exception is in the renal medulla. These patients sometimes still have loss of concentrating ability because they still get sickling problems in the renal medulla where the oxygen tension can be very low. And one unique feature of sickle cell trait is that there's an increased risk of renal medullary carcinoma, even more than is seen in sickle cell disease. And this is believed to be a consequence of the fact that patients with the sickle cell trait still have problems in the renal medulla. There are two commonly used tests in sickle cell anemia to diagnose either sickle cell disease or sickle cell trait. The first one is electrophoresis. This will show the presence of hemoglobin S. There are different amounts of hemoglobin S present depending on whether the patient has sickle cell disease or sickle cell trait. We'll talk more about that in a minute. A second test that is sometimes used is called a sickling test. In this test, you take a blood sample and you add a substance called sodium metabisulfite. This reduces the oxygen tension. Hemoglobin S will become insoluble as it does in the setting of low oxygen tension. This will form a turbid solution that is easily visualized. Other hemoglobin types will remain in solution, and this is a positive test if any amount of hemoglobin S is present, so it doesn't distinguish between the disease or trait. It just tells you that yes, hemoglobin S is present in the blood sample. This slide shows the electrophoresis patterns among patients with sickle cell disease and sickle cell trait. So normal adults have more than 95% of their hemoglobin as hemoglobin A. They have a small amount of hemoglobin A2, and usually 1% or less of adult hemoglobin is hemoglobin F. Patients with sickle cell disease completely lack hemoglobin A. They have a small amount of A2 and they have a variable amount of hemoglobin F. And the more hemoglobin F they have, the less symptomatic they will be. And then about 90% of their hemoglobin will be hemoglobin S. Patients with sickle cell trait have more than half their hemoglobin as hemoglobin A. Remember what I told you before. Their one normal beta-globin gene is more effective, and this generates more than half of their hemoglobin as hemoglobin A. They also have a small amount of A2 and the usual small amount of hemoglobin F, and then about 40% or so of their hemoglobin will be hemoglobin S. It's believed that the genetic defect in sickle cell anemia may have evolved because it's protective against malaria. Patients who are carriers for the genetic defect in sickle cell anemia, in other words, patients who have sickle cell trait, are protected against Plasmodium falciparum infection. This is the most severe form of malaria. When these patients get infected, their red blood cells sickle, and this increases their clearance, and along with clearing the red blood cells, the Plasmodium falciparum will also be cleared. Importantly, and this sometimes comes up in board questions, they're not protected against infection. They're just as likely to get bit by a mosquito and infected with malaria as anyone. However, when infection does occur, it tends to be milder and they're less likely to die from infection. And for this reason, these patients still need malaria prophylaxis when they travel to areas of the world where malaria is endemic. Sometimes children are born with one sickle cell beta globin gene and one beta thalassemia beta globin gene. In this condition, the sickle cell beta globin gene will lead to the production of hemoglobin S. The beta thalassemia beta globin gene will lead to production of hemoglobin A, but there will be less production depending upon how severe the genetic defect is. In the module on thalassemias, I talked about how patients with beta thalassemia with beta 0 genes have very little beta globin production. So patients who have this mixed with a sickle cell beta globin gene will have predominantly hemoglobin S production, and they will have a disease that is very similar to sickle cell disease. On the other hand, patients who have a beta 1 genetic defect in beta thalassemia can produce a reasonable amount of beta globin genes. They will have a less severe condition where there will be a significant amount of hemoglobin A, and they can behave closer to patients with sickle cell trait. The last topic for this module is hemoglobin C. This is a rare mutation of the beta gene that is different from the mutation in sickle cell anemia. In this condition, glutamic acid is replaced by lysine, not valine. Let's look at the bottom of the screen. This is the structure of glutamate or glutamic acid, and in hemoglobin C, it is replaced with lysine, not valine. Lysine is more polar than valine, therefore this is not as severe a change in protein structure as occurs in sickle cell anemia. It's very rare to be homozygous for the gene for hemoglobin C, but many patients are heterozygotes and they have a mild anemia with some degree of extravascular hemolysis. The classic finding of hemoglobin C in peripheral blood smear is the presence of hemoglobin C crystals. This is an example of one that I'm circling on the screen. These occur because hemoglobin C induces red blood cell dehydration. That leads to the formation of these crystals. It also raises the MCHC, which is another key finding in hemoglobin C. As I mentioned before, homozygotes for the hemoglobin C mutation are very rare, and heterozygotes usually have a mild anemia and do not have sickling. The one time where patients with the hemoglobin C gene can develop sickling is if they are born with one hemoglobin S gene plus one hemoglobin C gene. These patients are at risk for the same complications as in sickle cell disease, however they have a lower frequency of complications. This is sometimes referred to as hemoglobin SC disease to distinguish it from hemoglobin SS disease, where patients have two copies of the sickle cell anemia gene. Patients who are said to have SS disease have a more severe disease course and a higher frequency of complications. Patients who are said to have hemoglobin SC disease have a less severe disease syndrome and less frequency of complications. And that concludes our module on sickle cell anemia.